about every aspect that you have an interest in, including a lot of pictures on each article. We've given a course such as this at IMAST, which is the International Meeting of Advanced Spinal Techniques, called IMAST, here in Istanbul this week. But we also give courses around the world, and here are some examples. In 2006, we had another course here in Istanbul, but you can see the various areas of the world that we cover. This year, we'll be having extra courses in India, Amsterdam, Vietnam, Israel. So we get around. In September, we're having another big meeting in Chicago, United States. And then a year from now, our IMAST meeting, such as this, will be in Canada. So we continue to expand around the world. We love to travel to places such as this. It gives our members great opportunities to learn. It gives us great opportunities to meet people. I'm excited about today's forum here. We did this in Malaysia in December, and it was an outstanding experience. And I'm sure by the end of this day, we'll all feel the same about this one too. Thank you very much for letting me share some information with you.
Evet, bu güzel konuşma için.
We would like to thank the President for this beautiful presentation. I now would like to invite the second speaker, Peter Newton, will talk about what scoliosis is. He will give some general information.
Great. Well, thank you very much. It's an absolute pleasure to be able to speak with you today, visit your country and your fabulous historic city. I've had a wonderful time in Istanbul. My topic is, what is scoliosis? And I'll try to just describe the basics about scoliosis so that we can have some common language and understanding to move forward on the rest of our discussions this morning. First, we should talk about what the normal spine looks like. The part that develops scoliosis tends to be the thoracic and the lumbar regions, and those represent the areas of the spine that are in the chest. The thoracic part is the chest, and the lumbar region is the low back. And when we look from either the front or the back of the spine is typically straight, or nearly so. It doesn't have to be perfectly straight to be quite functional, but it typically is straight. But when we look at the patient from the side, we see curvature of the spine. And these curvatures are normal. In the thoracic area, we have typically a round back deformity. And in the low back, lumbar area, we have something called sway back. I don't know if you call them the same things that we call them. The spine is designed to move. The spine holds up the trunk, supports the chest cage, and inside the chest are the heart and the lungs, and inside the abdominal cavity, obviously many organs as well. So it's the main vertical structure of our body that supports our ability to stand and walk upright. But it's designed to move, and each of those vertebrae move relative to the other as we bend and twist. Well, scoliosis is a condition that may develop for a number of reasons, which we'll cover. But this is an abnormal curvature of the spine. So the typical curvatures from the side profile have now begun to move into other planes. And so when you look from the front or the back, you see a curvature that wouldn't be anticipated. This obviously then moves the things that are attached to the spine, like the ribs, into a different position and creates a deformity or an alteration in the shape of the body that you can see in the outline of this individual on the X-ray. This emphasizes that the ribs attach to the spine. And as the spine moves and twists, the ribs become deformed. And that rib deformity may cause alterations in breathing function. It takes fairly severe scoliosis to result in significant problems with breathing, but certainly in the most severe forms of scoliosis, we worry a lot about alterations in the function of the lungs. Scoliosis can come in quite varied severity, from almost none to remarkably severe curvature, which may result in a lot of dysfunction, difficulty breathing, and shortening and disfigurement of the trunk. And that same deformity in the spine results in varying deformities of the body that you see on the outside when you look at yourself or somebody who's affected. All three of these girls have some degree of scoliosis, although the one on the right is the most severe. We classify scoliosis based on its etiology, or what the cause is. And you will see that there are a number of different reasons that scoliosis may develop. The most common, and the one we'll spend the most time on today, is the so-called idiopathic variety. Idiopathic scoliosis means that we don't have a real clear understanding of the cause of the deformity or of this condition. But there are other types of scoliosis that are also common. Some are congenital. This is something that you're born with. This is a type of scoliosis where the vertebrae don't form properly in the embryologic phase. There are a number of other neurologic or neuromuscular conditions or associated syndromes in which scoliosis is fairly prevalent. And so we have quite a wide variety of patient diagnoses that may result in scoliosis development. Let's go back to adolescent idiopathic scoliosis, this most common form of scoliosis. The good news about adolescent idiopathic scoliosis is that most patients have small curves. And these small curves never really cause a problem. So when we look at the population as a whole, 2% of the population has small degrees of scoliosis. Very common and not causing any trouble or difficulty. Unfortunately, some curves are progressive, and those increasing curves we need to figure out, identify, and treat those patients. But the other thing that we notice is that the progressive forms of scoliosis in this variety, adolescent idiopathic scoliosis, tend to be much more common in girls. So this tends to be a disorder of adolescent females more so than males, but not exclusively. The ratio of operatively treated scoliosis is about 8 times girls for every boy. The cause of this form of scoliosis is, as I said before, not clearly identified, but we do know that this is a genetic condition. So we know that there is a tendency for this condition to run in families, and that there's something in the DNA that is responsible for the genetic code that is leading to the development of scoliosis more in some families than others. But it's not such a strong genetic factor that all family members are affected, or that even every generation is affected. So it may skip generations, and it may not be clear if you have idiopathic scoliosis who in your family tree it came from. Sometimes it's very clear because if you're a daughter, your mother may have it, but it's not always obvious. There are many other proposed causes of scoliosis, that there may be problems in the nervous system that are very subtle and difficult to identify. We know that the bones may be weak, the muscles may be a problem in supporting this fairly flexible column. The disc itself, the tissue that allows the motion between the vertebra, may be the primary source of the problem. We also know that this gets worse and develops during the phase of rapid adolescent teenage growth. So that rapid phase of growth is when scoliosis develops. So we know that there's some relationship to this growth as well. We suspect all these different tissues may be involved because there are other syndromes and medical conditions in which these tissues are problematic, in which scoliosis is common. And it makes us think that maybe very subtle forms of nerve, bone, muscle, or disc problem may be the cause of the problem in idiopathic scoliosis as well. When a patient presents for evaluation with scoliosis, the physician is going to ask a series of questions to try to get at what the potential cause of the scoliosis is and what the likelihood of the curve getting worse is. So these types of questions are important. How is the curve detected? Is there a family history of the scoliosis? Is it painful? Most mild forms of scoliosis are not particularly painful. I think many patients think that it should be when they see their x-ray, but most patients, at least in the early phase of the development of this adolescent idiopathic scoliosis, do not have a lot of pain. That may change as you age and as the curves become bigger, but at least initially it's often painless. We also ask regarding complaints regarding neurologic issues, numbness or weakness, which might signify some underlying neuromuscular condition that was unrecognized until now, which might put this then in another category of scoliosis. In girls, we ask about their menstrual history and whether they have started having regular menstrual periods. This is a very important marker of skeletal maturity in girls, which gives us an idea of how much growth they have remaining. And remaining growth is critical to understanding the risk of progression of scoliosis. So if that question seems odd, that is the reason for that question. And then we also want to make sure there aren't other medical issues that might be important to understand that would point to another underlying diagnosis that could be associated with scoliosis. The physical examination will be performed by the physician evaluating a patient with scoliosis, and this involves